The right coronary artery has an early bifurcation, and there is a tight disease in both the PDA and the PLV. And there was a little haziness in the PLV. So yesterday we did this angiography through the radial route. There is none of these lesions is ostial. So we did a 6 French angioplasty with 1 stent to the each artery and let him settle down over the night. So show the next slide. And this was the story on the left side. If you look at the circumflex, it's a large circumflex which gives a moderately large branch, obtuse marginal 2, and we have a 0-1-1 type of bifurcation stenosis. If you look at the LAD, that's around a 40% plaque in the LAD also, 40-50%. So a young 39-year-old male with 2 vessels, unstable angina was our substrate. We have treated the right, and now today the plan was to discuss this interesting bifurcation case with you. Show the next slides. Yeah. So it's a true bifurcation. And now we have 2-3 different strategies, and then we'll take the opinion of the panel. So if you can come to the current angiogram, the first shot we have taken today. First shot, right. So can you show today's live angio? Right. Can you all see this?
Yeah, we can.
So what we have done today is we have wired both the obtuse marginal and the circumflex. We have taken a 7 French guiding catheter. Now there are 2-3 different options for us. One option is that you dilate both of them. Just stay there, don't go forward. So we wired both of them. So one option is that we pre-dilate, prepare the bed. Praveer is suggesting that we dilate and then do a cutting for both these arteries, because there's a lot of plaque burden and we are ultimately likely to shift plaque from one artery to the other. Then either do a V stenting. So a V stenting, because there is hardly any plaque in the circumflex proximal to the bifurcation. The second option that we have is that we have a special bifurcation stent by Merrill. And there is for those who are not aware about this stent, we will describe to you, let's say the side branch is 2.5 and the main artery is 3.0. So one of the stents we consider would be a 3.0 to 2.5 side branch stent. The middle portion of the stent is devoid of struts. So once you prepare your branches, then you will deploy the stent first in the side branch and do a pot after this. And here in our case, how this stent will break up is, there will be a 10 millimeter in the proximal main vessel, there will be a 3 millimeter for the bifurcation area, and there will be a 6 more millimeter into the side branch. So unfortunately in our case, the side branch is longer than 6 millimeters, so we may have to deploy another normal stent into the side branch beyond the bifurcation stent branch segment. And after this part is treated, then we will withdraw the wire from the side branch and go cannulate the main branch. One of the main branch earlier wires will be trapped outside the stent. So after this, we will go ahead and do a culotte deployment of a longer stent for the main branch, because we see it's a long plaque. Once you have done a culotte deployment, we have already pulled out the jailed wire. We will use that to again go and cross into the side branch and end up with a kissing balloon. So this is a second way of doing this case, which is a little more complex. It took me a longer time to describe. And then Praveer was suggesting that we can also do our regular T stent or a tap technique for this bifurcation. We can discuss the 3 strategies that I have described. And
okay, who wants to go for? I don't know. The angle is good, but who wants to go for provisional crossover stent in the room? Provisional crossover stent, about 5, 6 people, 8 people. How about dedicated bifurcation stent, but the side branch is not good, not short enough. The lesion is longer here. Right. So nobody dedicated bifurcation stent. One person. And how about a two-stent technique with DK crush? Actually DK crush is what everybody is recommending, because I think even though you said there is no plaque, Atul, I think we have to prove that by no, actually, sorry, one more thing. How many people for V-stenting? V-stenting is only one person, Atul, I think, because even I feel that you have to do an IVUS to show that there is no plaque completely in the proximal circumflex. And so most people feel that if there is disease in the two branches, there's also a disease in the main vessel. Is that what? Okay. So DK crush or provisional stent strategy is what the maybe I would say 60% DK, 40% provisional. Surprisingly, actually, I would go provisional.
Right.
I don't know that is the OM very large enough to accommodate a 2.5 stent, and you can you do IVUS?
Yeah, it is. It looks like a 2.5. Yeah. No, we have not done any intubation in this as of now. We didn't want to start doing any even dilatation before we went live.
Do you want an IVUS first, or should we dilate? Because I think IVUS would not go in the OM.
Yeah.
Yeah. Dilate is okay.
And once we dilate it, maybe it's going to grow in size.
Yeah, if you pre-dilate and you don't have a large dissection and the flow is preserved in the branch, maybe he could do provisional, right?
Yeah. So there are two types of provisional, right? One is no touch technique. Don't touch the side branch at all and cross over.
Yeah.
But then if you pre-dilate, you should think that you might cause dissection. Sorry, Atul, go ahead.
So how many say that the side branch should not be touched at all?
Which balloon are you using to pre-dilate?
6, 8. You have taken a 2 millimeter stent, 2, 12, 8 atmospheres, it's broken.
It's 10, 12.
Okay.
14.
12, 14.
Yeah. Keep it.
2 or 10?
इससे length भी देख लेते हैं. Yes, 2, 15, 2,
15.
12, 2, 12.
2 into 15 NC balloon.
Okay, so it's a little longer than that, yeah?
15.
18.
No, 18, whatever
So this was 12 or 13 or 15?
15.
15? Okay, so this was a 2 into 15, sorry. So this is 12, 14 atmospheres pre-dilatation. You want to see a picture, or we do a dilatation for the circ?
Yeah, just go dilate the circ. I mean, I try to save contrast in diabetic people, then IVUS. If you don't have imaging, then you can take multiple pictures.
Yeah, he's a young guy, yeah. Yeah.
And how many of you would like to have a cutting balloon after this dilatation?
Cutting balloon? Only
Before
one person. So, I don't do cutting balloon because it's very expensive for us. I can get another stent for the same price. So, if IVUS shows fibrotic tissue, then I would go for...
If expense is not a problem.
Negative? Negative nahi hai.
You mean first the IVUS?
Negative.
Yeah, I would...
if IVUS shows it's a fibrotic lesion, then
we can use cutting balloon.
I think we'll take an IVUS. Fine, then we'll take an IVUS.
Do you have an IVUS ready? Huh? Acha, no, they're not ready yet. They'll have to take time. So we are skipping the IVUS.
Okay.
Okay.
Come back.
15, 2 or 15.
Go up, please.
Go up.
16,
6, 8. 10, 12, 13, 14, 15, 16.
Yeah.
17, 18.
This is very undersized. Okay. So this we have already sized, and alright, so that's how we look after the pre-dilatation. It's barely pre-dilated with a 2 millimeters. I'm taking these open.
See, once you dilate such lesions of bifurcation, I think there's a lot of plaque burden is there. It's always good to have good expansion of the stent if you have a cutting balloon there.
So you go with the cutting balloon now?
If you guys agree.
We have a 2.5 cutting balloon first for the side branch.
Yeah, I think go ahead.
So you can take that.
Okay.
All right.
One of the most important things
so
is
we'll take a 2.5 cutting balloon in the upper branch.
Don't change your practice. If you're doing
No, it's still good to keep you on our side.
yes,
Very politely nudging you on our side. Although you denied us a chance to show you a bifurcation stent.
we would have loved it actually. We would have loved to see. I was going to ask you if the side branch can go
that
into
would have
the
been very
bigger OM,
interesting.
but
Yeah.
it'll be too small.
Yeah, I think the
No, we have a strategy for that because we'll have to put a
Third
an extra stent in the OM beyond the side branch extension. So we still have an option. If you want, we can show you that.
right now we are just preparing the bed.
So this is a 3.0 or a
It's
And-
bulky, you know?
2.5? 2.5.
No, it's a
2.5.
2.5 in the side branch.
So it's
You
giving
see,
a little
see the
tough time.
fibrosis?
Yeah.
After the dilatation with the balloon also it's not going.
Probably calcified.
So this is what is the fibrosis in all these lesions.
So we'll
Yeah.
take the three, put this first in the circ,
Yeah.
you know, and see if we can soften up the
Yeah.
bed.
So what
So-
we'll do now, we'll change our strategy of taking 3 down first in the...
No,
in
we'll do 2.5 first, and then, you know, we have this ready, prepared.
okay. you can
Try and
go
put this in the circ. Yeah, coming back.
ahead. See that. I hope I've not pulled the wire.
Yeah, let's see. No, we are still there. Okay.
So we're going with the same balloon in the main branch now.
2.5 cutting because the angle of the OM was quite rigid. You know? And this is a stiff balloon, 2.510.
Yeah.
And it has seen some other vessels also.
So, but after that, will you get a stiffer wire in OM1 and do cutting or no cutting in OM1?
It's an all-star
no,
wire.
we'll do that.
Yeah.
It's a already all-star wire.
See that?
See that? How stiff is the lesion? Still, this is not even crossing the... So we have to upsize our regular balloon first. We can have a 2.5,
You're making
2.5,
some progress.
15. Yep.
No, we need to have a good bed to
Yes.
send a cutting balloon. Wait.
Okay.
No, it's holding the wires.
Okay. Fine.
But
2.5. See, 2.5 same mosaic NC balloon.
the OM branch, the angle is very narrow for the.
Now we should tell you this first, otherwise nothing will go.
Bend.
Yes.
Yeah. So, but he
Yeah.
tried the second attempt was
It's
into
not
the,
angle, it's a
the
hard
second OM.
It's a hard
Even that
angle, I
they
think,
couldn't advance. Actually,
Yes.
how many would use
Yeah.
the
There's no
buddy
angulation
wire
there.
here? Now? No buddy wire?
Let us just dilate it a bit more. And if you notice, the balloon was, when it was inflating in the OM, it was taking a shape of the plaque.
Yeah.
So that was telling us it's a really hard one to crack.
Okay.
Yeah, go up.
Go up.
1, 2, 3, 4,
5, 6,
7,
10,
8. See that angulation?
25 enter.
8, 9, 10, 11, 12, 13, 14.
Negative.
Deflate.
He's getting pain. Huh?
Yeah, he will.
Okay, take a picture. Have you dissected or?
You can take a small shot. Because
Okay, so this is a. Okay,
Yeah, okay.
we are not badly dissected.
Can you advance
This again goes into the.
let's see the wire.
So we also do
Cutting
what,
balloon? We'll do
Manish
that.
No,
has
this is
described
the
earlier.
simple plain 2.5 balloon.
So once the balloon is up, now it's unwrapped and try to advance the balloon again. If it goes in, then the cutting balloon probably will go. This is an NC balloon, right?
Okay, yes, it's an NC balloon.
Yes.
All the
Okay.
Coleman's Ibis.
So now this is 2.5
Going in the main vessel.
in the main vessel.
So it looks like you also avoided the V stenting because now you touched the proximal circumflex, right? You pre-dilated
Yeah,
the
now we
front.
decided to touch, yeah.
No, it will
Because
be,
the,
yeah.
yes, we have done that because there was the,
I agree.
that was the area where there was resistance, you know.
Yeah, we all
Yeah.
agree.
Slightly down because
Shows the
slightly
angiogram.
more.
Ah,
Yeah, go up.
go up, please.
6, 7, 8,
Can you show
10,
the
12,
angiogram?
14, 16, 18. Deflate. Can we have this angio on the screen? अरे नहीं, there.
Live at me. Okay, take a picture.
Some room is there now.
Yeah.
Let us try the
So
cutting
we-
again.
OM1 looks bigger now, right?
Okay.
Maybe.
Yeah.
Yeah, it will grow.
We thought
Right.
it, always we thought it was a 2.5.
And there's no other OM, so it has to be large.
Maybe bigger than 2.5. Size.
Yeah, let's see how do we end. It's again a diabetic vessel. So this is a 2.5? All right. So we are trying the same cutting balloon once again.
No, this won't take the curve. It might go.
No.
Put
So
no
we
pressure.
need an ETO, you know? He's getting pain. Correct.
Why don't you do IVUS and see?
Although the balloon has opened well. IVUS catheter है? Yeah. IVUS catheter कहाँ गया? लाओ ये खोल दो. Yeah.
Yeah.
Okay. All right. So basically, we know what we are dealing with. It's not calcium or
Right,
it's
right.
fibrotic, you know. It's
Right.
So
now we are trying an
So we are not pushing
like
too
an
hard for an
angiosculpt
IVUS,
now.
you know. This is a bend again, and
So I'll start first and
let's try and treat it. So we've got an angiosculpt 2.5,
oh, I thought you tried that.
and
that was
let's
still a
see how
cutting board.
better we can. No, that was a 3-0 cutting, you know. That was a 3-0 cutting.
Yeah.
So
Yeah.
this goes.
Well, this will be
Check.
cut there. This will be cut there.
Further down.
पाक पूरे support है.
That's good.
Okay, go up.
1, 2, 2.5, 3, 3.5, 4, 4.5, 5, 5.5, 6, 6.5, 7, 7.5, 8,
Okay.
8.5, 9, 9.5, 10. Good enough. Deflate. Now we just cut
Push.
both.
I'll just put it back,
Yeah.
you know.
Yeah. Just delete as it will cut. Yeah. Can I check?
Wait.
That
Okay, sure.
Not okay. Go
All
up.
right. Go up.
1, 2, 3, 4,
2, 4.
5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. Deflate. For guiding under
20, 25 more.
guiding under
हाँ पीछे ले लेता हूँ.
Having pain?
Yes.
Yeah. So
We
giving
have
him
not
little
been nice
more.
to the arteries, so he will have pain.
Wait.
Dr. Agarwal,
So now we take this.
let
Yes.
me ask you a question. In your personal experience with angioscope, you can go up to higher pressures. So what is your limit?
You can.
18
Yeah.
atmospheres in your clinical
Limit is
practice?
about 18.
Yeah, that's what we do also.
Usually 18.
That's why we were wondering. That's why I think
Negative.
Enrique is asking.
And the cutting
how
the
come you
limit is
stopped at
further
14?
higher.
Negative करो. पूरा नहीं हो रहा.
No, approximately we did 18.
Please careful. No, I can
And
feel it
not
here.
28 like in the other case, right?
No. Haven't tried it. These wires have gone a little forward. हाँ
यही काटना है.
ये यहीं काटेंगे है ना. That's bifurcation. आगे तो soft है. Okay, go up.
6, 7, 8.
Yes.
9, 10, 11, 12, 13, 14, 15, 16, 17, 18. Deflate.
All right. So here we are just cutting the bifurcation.
That's the cutting balloon, right?
And now let's
Give
strategy. Yeah, this is a angiosculpt.
No, angiosculpt.
Angiosculpt.
So now we'll make a strategy as for the stenting.
But it's 2.5, so at about 18 this becomes nearly 2.75.
Wait.
Sorry. Taking.
Yeah, stick kara.
Okay, nitro.
All right. Nitro? Here you go.
Nitro देते हैं. अब तक आप wire.
All right, we'll give a little nitro, take assessment of the sizes. Ready?
Sorry.
Ready?
Yep.
Okay. So you can see some dissections in both the vessels.
Okay.
So our
But
first
can we just go
stent,
more caudal? And
caudal
bit
बढ़ा
aleo.
दो,
Bit aleo.
AP आ जाओ. हाँ.
Yeah. Yeah. Now we see this.
All right.
So we'll be seeing it much better. Okay. So now
This is at least 18.
18. They have 19 with them. So I think
We can take a 19.
2.5 19.
So we are taking a 2.5 19 stent for the opus marginal.
So what strategy? Is two stent strategy, but what are you going to do? DK crush, mini crush?
Yeah, crush. Mini crush.
Yeah, DK crush. DK crush.
DK crush.
एक और इसमें balloon डाल लें.
Can we have a 3 balloon?
Give me a 3 balloon.
Mark, you agree?
313. And we are going to put a 3O balloon on the main vessel.
Non-compliant.
Yeah, non-compliant.
Ah, that's where you are. Okay, can you just pin down this wire?
You see, despite angiosculpt and a all-star wire, it's difficult to go with the stent. But it's inching there.
Made it.
Okay, there we are. So that was the bend, our friendly bend that you have been.
That did not let the cutting balloon go.
So it was good that we did a cutting, otherwise this stent would have had even more difficult times. Precious.
हाँ, पास line देंगे.
I just
Fluid
want
fast
to
है तो
ask the
100
panel,
ml sister.
how many would use IVUS in these patients in this type of non-left main bifurcation routinely?
No, we know.
I mean, most of us don't use IVUS in every patient, right? It's only in the United States only 20% usage.
Pull this one back.
And in Brazil, the probe for IVUS costs $1,000. What about in US?
Right.
About 600, 700.
Sister, fluid there, fast. Okay, good. Check please. That's it. One more shot and then we'll go up with our stent. Are you happy?
Yep, I'm happy. And if everybody's
Go
happy,
up with the stent. 2, 4, 6, 8, 10. Negative.
The lesion is difficult to yield.
Okay, go up
Yeah.
with this balloon again.
Go with the balloon. Yeah.
Stent balloon, no, only stent
Stop.
balloon.
1, 2, 3, 4, 6, 8, 10, 12.
Negative.
3, 5.
So now we do a check shot.
Yeah.
How many people
I'll
remove
pull
the
out the
wire
balloon
for the
first.
first crush? Right.
No, it's not required to be removed.
All right, we crush.
अभी थोड़ा सा आगे कर दें कुछ approximately हो जाएगा.
You're going to remove the wire? No,
Check, please.
हाँ.
Okay.
Go up.
Go up with the balloon. 3O balloon.
Go up.
Hey, एक minute.
301.
Should we take out the wire
No.
before we side branch?
क्यों? जब स्टैंड लगा इसको निकालेंगे तो
Okay.
निकालेंगे. 1, 2, 3, 4.
To get a good
5,
crush, the recommendation is to take
7,
out, but
8,
I've seen other
9,
people
11,
not
12.
to take it out. And
13, 13, 14.
Negative.
हाँ.
Negative. Good.
Okay. इसको निकाल दीजिए पहले balloon को. Right. So that's it.
as
This is
compared
our
to
cert.
provisional, you have to cross from the proximal cell
Other
for
balloon.
DK crush to get a better
Yes.
Sorry.
stent apposition.
Yes.
Sometimes
Take
there's
this
only
out.
one cell,
Yeah.
half a cell.
Balloon out, then we take a shot. अच्छा. Can we have 332?
Wait, don't pull out anything.
अभी नहीं. But जब instant place हो जाएगा, that time we'll take it out.
Yeah. Wait, I'll give you.
हाँ. No issue.
All right.
Okay.
I think we'll,
let us just
we'll
take
look
a
at all these steps. It's very good to see DK crush.
Pressures are good.
I think in the morning we were discussing most people either prefer crush, but DK studies have all been shown that DK crush is better than
Shot लेने?
provisional as well as better than crush,
Small chip.
better than culotte.
Okay. So there is some filling defect in the bifurcation area.
Yeah, that's all marked there.
So the only problem is, did we cover the ostium, Manish?
Yeah.
Now before this thing.
So you're doing a crush technique.
Right.
This is not DK, so you're doing a crush technique.
Yeah.
Okay. Now we take the wire out.
Take a All-Star NY, or this wire may not be good. Okay, so we are going to take out our side branch. So the patient had a little hypotension in the meanwhile.
Yeah.
So
Oh, sufficient enough. Last shot. Can we see the last shot?
take one more. I'll adjust according to. ठीक है? Good.
Bit back.
Go up.
नहीं, पहले देखिए कुछ थोड़ा.
Not convinced that we covered the ostium.
Yeah, it's fine.
Go up. 2, 4, 6, 8, 9,
10, 12, 13, 14,
इसका यही है.
15, 16. On the side.
So
17,
this is
18.
BioMime.
Take a second.
Yeah.
Yes. Aura.
Aura. This is a
Deep, deep
32. Negative 332.
Now we want 3.5 balloon for this side and 2.5 balloon for the main branch.
So LED, the circumflex main vessel is looking bigger. That's why we went up to a little higher pressure of deployment.
I think
So at 18, this becomes nearly
Wait, wait,
3.31. And still it was slightly undersized, so we'll take a 3.5 to post the lid.
good.
Wire the OM. Give me a fresh towel, small towel, please. Got a shape?
Yep.
Okay.
We just have few more minutes with you, so show us how to recross and.
Oh, okay. So let's see. I know how much we can show you.
Okay.
But it was interesting discussing all this with you.
No, this is a very interesting case.
Yeah.
Which wire is going to use to
Doctor,
recross
please.
stent?
All star.
Again, all star. What wire do you use
Yes.
Jaeger, to recross? What wire is your choice?
PT
Check.
graphics.
Show me.
PT graphics.
PT graphics. How about you?
Whisper.
Whisper.
Shape कम है शायद.
Fielder. Fielder.
Shielder. XT.
Fielder FC,
FC.
or regular fielder wire.
You see, fielder is
Short. Just to make
fielder is a
sure.
good tip, but the body is soft.
Okay.
And seeing that bend, it's a bit tricky to go with the all-star, but for instance, it gives a good support to you.
Right. No, the only thing I was thinking.
So
all-star,
hemodynamics
the
are
tip
quite
can get
stable
easily
now.
Damaged. The tip is very soft and all star. And
Just
it-
2.5.
क्या है?
Yeah.
2.5.
15.
15. Okay. So a 2.5, 15 again for the side branch. Let's see we
might
have
go for an
whether we
NY
have an
treatment.
intertwining or anything. Yeah. So there's a resistance. We need an NY, you know?
Yeah. Can we have NY?
Let me see where
Maybe
I'm getting
doing a
stuck. You know,
pod.
whether I need to rewire again.
No.
Pot only in the proximal part.
So that's where it is getting stuck. So it's beyond the origin of the stent.
See. Give us an NY.
The new
13.
balloon.
Or,
That's probably
Or
not.
even
Yeah, yeah, yeah.
or even a smaller one.
Before trying a smaller balloon, maybe you could do a
You have eight?
pot
Wait.
with a 4.0, maybe 3.5 higher pressure only in the proximal part. It sometimes helps a lot to cross.
Yeah, if it doesn't go, we'll do that.
So he's saying pot
Right.
would help us to get the balloon on the wire. The wire went, but the balloon is not going in. I agree.
Exactly.
We do a pot and then
Thora
final
ile
kissing
tadına.
balloon and then
Are
end
you
with the
recording?
pot.
So we are trying a new balloon because initially we used the
Yeah.
previously
Yeah.
used balloon.
Oh yeah,
This was
new
used
balloons
initially to
always
dilate.
for the final kissing.
Yeah.
Okay, hold. No, same.
Yeah. Yeah.
A
Even
smaller
pot
balloon
would not
maybe?
help.
Maybe a compliant balloon? Huh?
No, not a compliant balloon.
Huh? Yeah, or we have through a strut, you know.
So do the pot and
We'll
then
rewire it again. One introducer.
Okay, let us pot first.
Yeah.
Give us a 3.5 balloon. Keep it there only.
Yeah,
Keep it
just-
there only.
wait.
So sometimes
Okay.
helping the recrossing via
You know.
another cells. Well,
Yeah.
Yeah.
It's good to do the pot before rewiring because
You see,
sometimes doing the pot you can rewire in
exactly.
You see, pot at times can be problematic in case the wire has gone through a strut, and if you do the pot at high pressures, the wire may not come back.
So that's what he was saying. So pull back the wire and
But still we are trying.
इसको थोड़ा इधर shift कर लो.
do pot
Do the pot and then again rewire it.
and then rewire it.
I think it's a good idea. We have to, yeah.
You take the wire out.
Yes.
Huh?
We take the wire out
Take both this out.
At least into the
and we
guide.
rewire it. Yeah. Because supposing it's
Okay.
gone through a strut.
Okay. You can separate out the wires. And so there is
A
an
lot of
issue.
resistance.
Yeah. Okay, go
Okay,
up.
go up.
6, 8. Are you connected? All right. So we can go up 6, 10, 12.
14.
Negative. Negative. This is a 3.5.
Yeah. Now try go up and down.
Yeah.
See that?
So this is still post-dilatation. When you say pot, you expect it to be a shorter
Yeah.
6 millimeter balloon, just proximal to the
Yeah.
from the carotid.
You didn't have an 8, on this. Wait.
Keep
All
it
right.
there.
So now
We'll be
let's see if
requiring
we
it
can
in-
rewire our.
Okay, just show us rewiring, and then we'll
Obtuse
probably
marginal.
leave you to complete the rest of the work.
All right.
and
Okay.
excellent result, though.
Okay. So just give us a moment to see whether this balloon goes well, and otherwise you can tell us whenever you're going off. Okay?
Sure. We'll get my slides ready and.
Okay.
Yeah, it is
Are we
going.
outside?
Can you
Huh?
please go in this way?
Huh?
It's going this way.
No, it's not.
It was going.
Let's see.
It's going. आगे. Yeah, it's going.
There we are.
Okay, wonderful. Thank you very
Okay,
much.
so we are
Azul.
through. Take another balloon. Yeah.
Okay, thank you very
One.
much for a great
3.5 balloon,
demonstration of
please.
this complex
Okay.
bifurcation.
Bye bye, all of
lesion.
you.
Thank you.
Thank you all.